Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in session number 6, and this is our final session of our new program entitled X-Rays and Medical Research in the Qualified Medical Evaluation. And I have a fascinating program for you today, which is going to perfectly illustrate the take-home messages of this entire program. And before we get into today's discussion, let's just briefly reiterate and remind ourselves of the philosophy of sessions 1 through 5 of this program. The overriding philosophy of this program is that X-rays are, in many cases, almost 100% of cases, at least involving the spine, involving the upper and lower extremities, X-rays are nearly 100% required in every single case. And many doctors tell me that they neglect to order the necessary X-ray diagnostic studies, and they cite for me about 100 different reasons to why it's so difficult to get the X-ray studies ordered and completed within a 30-day time period, and 100 reasons why they simply decided to drop this procedure out of their normal operating practice. And I want to remind you that there is no good reason to not order the necessary diagnostic studies in every single case. And let me give you an example. Let me give you a couple of examples. If you have a spine injury case and you're assessing the examinee out of Chapter 15 of the AMA guides, and you neglect to order flexion and extension radiographs for that examinee, then by failing to order the flexion and extension radiographs, you're failing to assess the examinee for an important impairment. That impairment has to do with loss of motion segment integrity of the individual vertebral segments. So by neglecting to assess the examinee for the presence or absence of that impairment, you're doing a grave disservice to the examinee. What if the examinee actually has that impairment and you neglect to assess the examinee for that impairment? That does a grave disservice to the examinee who deserves consideration for that impairment. Similarly, let's say, for example, in Chapter 17, if you have a hip injury case, a knee injury case, an ankle injury case, and you neglect to order the required X-ray studies, then by doing that, you're making a conscious decision to neglect to assess the examinee for post-traumatic arthritis. You're neglecting to measure the cartilage intervals, which would tell you whether or not the examinee has or does not have impairment due to post-traumatic arthritis. By neglecting to assess the examinee for impairment due to post-traumatic arthritis, you're doing a grave disservice to the examinee and a grave disservice to the parties, especially if the examinee actually has that impairment. So I want to encourage you to order the necessary diagnostic studies in every single case, no matter how difficult it may be. And I acknowledge and I agree with you that it is many times extremely difficult to get these studies ordered and done in a timely fashion, but we're required to do this for the examinee because the parties are counting on us to provide a qualified medical evaluation report that's accurate, that's as close as possible to an accurate representation of the examinee's true condition. So I encourage you to order diagnostic studies in every single case. Number 2, many times when we order the diagnostic studies reveal findings that we could never have anticipated without the diagnostic studies. And many times these unanticipated findings create a need for new medical research in order so that we can understand the significance of these findings on the examinee's circumstance and on the relevant issues related to disputes in the examinee's case. So in the future, QME reports are going to be required to incorporate medical research into the opinions and conclusions. Even though their medical research is not now required, it's my recommendation that we should begin to adopt medical research into our reports now and start to incorporate medical research into our opinions and conclusions so that our opinions and conclusions can better qualify as substantial medical evidence. And I want to illustrate this principle just one more time before we get into today's discussion. You know, when the parties hire us as qualified medical evaluators, they do that for a reason. They do that because they believe that the qualified medical evaluator is going to get to the bottom of the issues and will discover the truth and will discover the facts and will report the facts and will report the truths in their report. And the parties are relying on the opinions and conclusions of the qualified medical evaluator. And let me tell you a story to illustrate this principle. I recently received some correspondence from a business owner in Southern California, and he was looking to me for help, and I don't know how he got my name, but he got my name somehow, and even though I wasn't able to help him, he contacted me with his story. And he told me that 25 years ago, he and his wife decided to go into business for themselves, and they bought a small 9-hole par 3 golf course in Southern California. And it was extremely difficult getting the golf course going, but they persevered and they persisted, and slowly over the years the golf course gained in popularity and gained in attendance, and they were able to eke out a small living by running a small golf course. Well, for approximately 23 years, the first 23 years in operation, they had only 1 or 2 injured worker injuries in the course of the routine running of the golf course. Okay, but in the last 3 years, the most recent 3 years, they had a rash of claims for workers' compensation claims due to reports of injuries on the job at the golf course. And this business owner wrote to me and he said, what am I going to do? My workers' compensation premiums are going through the roof. It's threatening our financial solvency. My wife and I are terrified that we're going to lose this business. And these workers' compensation claims are not legitimate claims. He stated that the last employee that claimed benefits for workers' compensation was recruited to do so as he was leaving the parking lot of a local Walmart, when someone in the parking lot came up to him at the local Walmart and encouraged him to come over to a booth. And outside the Walmart was a booth that had a banner that read free medical evaluations. And it was through this recruitment that this employee decided or was encouraged to file a claim for workers' compensation benefits against the owner of the golf course. Well, imagine that you're the owner of the golf course and you learn of this claim. And you wonder what is going to happen with this claim. But you're encouraged because you learn that the employee is going to have a qualified medical evaluation, that the employee is going to be evaluated by a qualified doctor, a medical professional, who will get to the bottom of the facts and determine the truth of this employee's claim for industrial injury. And you wait and you wait and you wait and you're wondering, what is the QME going to say? What is the QME going to report in his report? And you're relying on the conclusion of the QME's report. Well, this employer, as well as the employee, as well as the claims administrator, as well as any attorneys involved with the claim, rely on us for opinions and conclusions that are truthful and accurate. And many times, truthful and accurate conclusions can only be arrived at through ordering necessary diagnostic studies and conducting necessary medical research. And in today's discussion, I want to share with you a case that illustrates these principles perfectly. It has to do with an examinee who had a claim for industrial injury, and the necessary diagnostic studies showed some fascinating findings that, absent the diagnostic studies, could never have been discovered. And I want to share with you how the qualified medical evaluator used those findings on the diagnostic studies to arrive at an opinion or conclusion on causation. The dispute in this particular case was on AOE-COE causation. So with no further ado, let's begin today's discussion, which has to do with kidney stones in the qualified medical evaluation. Okay, so let's begin. Today's case involves a 54-year-old male fast food restaurant relief worker. His job title was what they described as a relief worker. So that means that he was not a cook at the fast food restaurant. He did not work the front counter at the fast food restaurant. His job duties involved cleaning up the lobby, stocking napkin holders, unboxing shipments of food back in the storage area. So he was entitled a relief worker. Well, his job involved showing up at work at 6 a.m. to do whatever duties were necessary. And he worked 3 scheduled 8-hour days per week and then was assigned additional working hours as the need arose. But he was a part-time, 24-hour per week relief worker. Well, on the date of the industrial injury, he reported that he was lifting a mop bucket when he felt a pain in his lower back. And at the face-to-face evaluation, the qualified medical evaluator did something quite interesting. The qualified medical evaluator did a search on Amazon.com for commercial mop buckets. And the examinee picked this particular mop bucket out of a list of images of commercial mop buckets. So the qualified medical evaluator did some research and determined that this was a 26-quart mop bucket. Now 26 quarts is 6.5 gallons. So when this mop bucket is completely full, this mop bucket weighed approximately between 40 and 55 pounds. 40 and 55 pounds. Well, he stated that he reported this incident to his manager, and his manager did nothing and did not help him file a claim form and did not suggest that he pursue any industrially related medical care. So on his own, the employee left work and presented to the local emergency department. So the examinee, on his way home in the middle of his work shift, stopped by the local emergency department. And here is the notes from the medical records from the first medical encounter following the report of industrial injury. So this is on the same day, within an hour or within 2 hours of the reported industrial injury. The notes tell us that the examinee reported that he experienced lower back pain, which had its onset today after picking up a water bucket while working. So here is the indication of an industrial injury. It states while working. Those 2 words suggest that this is an industrial injury, and these 2 words are taken from the employee's testimony. Okay? On exam, the medical provider discovered diffuse tenderness in the right lateral lumbar area along the mid-posterior clavicular line with associated muscular hypertonicity. So this is an interesting finding. The finding is not located on the spine itself, but it's located off the center of the spine in the mid-clavicular line. So this is along the flanks to the lateral aspect, or the right lateral aspect of the spine. So the medical evaluator is not reporting an injury directly to the spine, but is reporting findings off to the right of the spine in the flank area. So the diagnosis is nonspecific back muscular spasm. The treatment rendered was naproxen and tizanidine medications. And the emergency department recommended that he follow up with the occupational health clinic due to report of an occupational injury while working. And the medical records indicate that there was no follow-up with the occupational medical clinic. The very next medical treatment occurred approximately 30 days later. So if we look at this medical record from the first provider to evaluate this injured worker, what objective conclusions can we draw based upon this brief medical record? Well, the qualified medical evaluator drew the conclusion that the medical provider at the emergency department was not too concerned for a serious condition, for a serious spinal condition. And evidence that supports that is the fact that there were no x-rays required. No x-rays were obtained at the time of the initial evaluation. So that suggests that the medical provider was not too concerned for a serious spinal condition. And the diagnosis does not involve radiculopathy or any particular spinal injury type of diagnosis. The diagnosis is sort of a generalized and nonspecific back muscular spasm. Okay, so at least we can conclude here that based upon the mechanism of injury as it was reported to the medical provider at the emergency department, the medical provider was not overly concerned for a serious medical spinal injury. So the medical provider was not overly concerned for a serious spinal injury. And the examinee continued to work, but he was given reduced working hours due to his complaints of back pain with various activities at the fast food restaurant. So for example, one of his duties involved unpackaging shipments of product that came into the loading dock of the fast food restaurant. So in unloading cans and boxes and products, he reported lower back pain with this type of activity, and because these were his required job duties and because he was unable to perform those job duties had to be assigned to another employee, and so there would be no need for this particular employee, so they reduced his working hours to be compatible with the activities that he claimed that he was able to perform. So 30 days later, after the date of industrial injury, he did not follow up with the occupational health clinic as was suggested to him by the emergency department, but rather he self-procured care outside of the employer's medical provider network. And he continued with this self-procured care for approximately another 30 days while he continued working, at which time the new medical provider, the new primary treating physician, provided him with TTD, total temporary disability, due to his complaints of ongoing lower back pain with work activities. Well, he was on TTD for approximately 4 months, during which time he continued to receive medical treatment. And during this 4 months of total temporary disability, he reported only partial resolution of his lower back pain symptoms. So he reported ongoing lower back pain symptoms despite time, despite medical treatment, and despite total temporary disability, which took him away from injurious activities at the workplace. Well, the claims administrator denied the claim due to the fact that the claim was involved in unwitnessed incident of injury with a relatively minimal mechanism of injury that seemed to be out of proportion to the examinee's extent of suffering, now going on 6 months beyond the date of the reported injury. Well, this created the scenario for a Labor Code 4060 compensability exam to resolve compensability disputes for this denied claim. And the QME exam was scheduled as soon as possible, but could be arranged no sooner than what amounted to approximately 6 months after the day of the reported injury. So at the qualified medical evaluation, the QME conducted a lumbar spine evaluation, and here are the impressions taken exactly from the QME report, which describe the findings of the lumbar spine examination. The qualified medical evaluator stated that Mr. Jones had a slight restriction to lumbar spine range of motion in lumbar flexion, and to a lesser degree also in bilateral lateral flexion. Slight restriction in 3 out of 6 ranges of lumbar range of motion. And although Mr. Jones reported stiffness with these movements, there was no report of pain with these movements. So in going through these ranges of motion, 3 out of 6 ranges of motion were full and complete and without report of pain. 3 out of 3 were without report of pain but were slightly reduced, and the examinee reported that he felt stiffness in these particular ranges of motion. So the qualified medical evaluator concluded that because there was no report of pain even at the end ranges of these restricted ranges of motion, that these ranges of motion represent Mr. Jones' currently normal range of motion. In other words, the ranges of motion were slightly reduced, but they weren't reduced due to report of pain. There was no report of pain with the range of motion. And additionally, there were no findings for radiculopathy, and the remainder of the examination was negative for impairment of function of the lumbar spine. So the examinee had normal reflexes, normal neurologic exam. He had normal good strength to strength testing of the lumbar spine, and there were no findings for either verifiable or non-verifiable radiculopathy. So this describes a relatively benign or mostly normal lumbar spine examination, which seems roughly consistent with a minimal musculoskeletal injury approximately 6 months ago, for which the examinee had received adequate medical treatment and for which the examinee has had at least 4 months of total temporary disability. So a relatively benign or normal lumbar spine examination. So in providing for a complete evaluation, the qualified medical evaluator did as he's supposed to do, and he ordered lumbar spine x-rays. And here are the findings of the lumbar spine x-rays as described by the medical radiologist. The findings stated that there's no evidence of malalignment on flexion, extension, or neutral views. The vertebral body heights are maintained. There's mild loss of the L5-S1 disc space height. There's no evidence of a pars defect. The sacroiliac joints appear unremarkable. There is a coarse calcification in the right mid-abdomen, which measures 2.4 centimeters. And 2.4 centimeters is approximately 1 inch. Additional coarse calcification in the right mid-abdomen measures 1 centimeter. Impression, no evidence of malalignment, mild degenerative changes at L5-S1, and coarse calcifications in the right mid-abdomen could be secondary to renal stones. And here, the qualified medical evaluator indicates to the reader of the report that there's going to be some medical research below related to these findings of coarse calcifications and the possibility that these coarse calcifications could be due to renal stones. So I love this reference that the qualified medical evaluator makes here early on in the x-ray findings. He alerts the reader of the report that there will be a section later on in the report that addresses these findings. And he introduces the concept of medical research here early in the X-ray or diagnostic study section of the report. And then the qualified medical evaluator did what I recommend that all of you do, and that is, in addition to the report of findings provided by the medical radiologist, you provide your own report of findings on the X-ray images. Let me say that again. I want you to perform your own report of findings on any images that you receive. Don't simply rely on the report of findings of the medical radiologist. You need to conduct your own review of the images yourself and provide your own report of findings of the images. So here, the qualified medical evaluator does a fabulous job. He does a report of findings based on each and every image of the lumbar spine x-rays. So on the A to P lumbar, he gives a complete report of findings that there are 5 normally formed lumbar vertebrae. The alignment of the lumbar spine is normal without scoliosis or other curvature. The L5-S1 articulation is normal. There's no findings for a transitional vertebra. The disc spaces are preserved throughout. Sacroiliac joints are normal. There are 2 calcific densities in the right abdomen adjacent to the L3 and L4 vertebrae. Medical radiologist Town, MD, referred to these as could be secondary to renal stones. And here again, the qualified medical evaluator makes reference and alerts the reader that there's going to be some medical research below to explain the findings and the significance of renal stones. On the lateral lumbar, the qualified medical evaluator stated that the lumbar lordosis is normal, and he measured it even, at 61 degrees. This is a fabulous report of findings, by the way. The disc spaces are preserved throughout with perhaps early posterior thinning of the L5-S1 disc. Again, noted are the two calcific densities, one of which overlies the antero-inferior corner of the L3 vertebra. In this projection, there are no findings for degenerative change. On the L5-S1 spot, he tells us that the L5-S1 articulation is normal, but there is perhaps early posterior narrowing of the L5-S1 disc space, but still, there are no findings for degenerative change. The report of findings continues. He tells us that on the sacral base tilt projection, the L5-S1 articulation is normal. There's no findings for lumbosacral transitional vertebra. The transverse processes of L5 are normal. There's no spina bifida of either L5 or S1. On the obliques, the pars interarticulari are intact, and there's no evidence of spondylolysis or spondylolisthesis. The facet joints are normal throughout without findings for degenerative change. Same findings on the right posterior oblique. On the flexion view, the spinal intersegmental relationships are intact, and there's no evidence of ligamentous laxity. The lumbar lordosis reverses normally on flexion. Disc spaces are preserved, and there are no findings for degenerative changes. And the qualified medical evaluator refers us to the analysis of motion segment integrity below. Remember that lumbar flexion and extension radiographs are used to assess for motion segment integrity, and here he refers us to that study, which is outlined below. Same findings on lumbar extension, as there's no evidence of ligamentous laxity, and see analysis of motion segment integrity below. So wow, this is a fabulous and complete and thorough report of findings of the lumbar spine x-rays, and basically the qualified medical evaluator addresses many conditions that could be cause of pain in this examinee. He tells us that there's no transitional vertebra, there's no spina bifida, there's no spondylolysis or spondylolisthesis, and the qualified medical evaluator here does a fabulous report of findings. Okay, and so let's take a look at the x-ray images here, and we'll just go through these quickly. So here's the AP lumbar, and you can see that there's relatively straight alignment of the lumbar spine. The sacral ala and iliac crests are aligned well, and there's no scoliosis. There are 1, 2, 3, 4, 5 normally aligned lumbar spine vertebrae. And then here are the calcific densities in the right lower abdomen as described by the medical radiologist. Here's the first one, and then here is the smaller second one. Okay. Looking at the oblique projections, the pars interarticulari are all intact. There's no spondylolisthesis, no spondylolysis, and the facet joints, both the superior and the inferior articulating facet joints, appear to be healthy and without degenerative change. Same goes for the left posterior oblique. Those are beautiful facet joints with no degenerative change. Beautiful oblique projections with no findings for spondylolysis. Here is the lateral lumbar, which shows 61-degree lumbar lordosis. All the lumbar disc spaces are intact, are fully formed, fully patent. There is perhaps early thinning at the posterior L5-S1 disc. The anterior L5-S1 disc looks full, and the neuroforamen throughout are patent without encroachment. And here is the calcific density anterior to the superior end plate of the L3 vertebra here. The other calcific density we cannot see because it's overlying the inferior end plate of the L3 vertebra approximately in this region right here. Here is the flexion view. Here is the extension view. L5-S1 spot shot shows normal L5-S1 articulation. There's perhaps early thinning of the posterior aspect of the disc space here, but alignment of the L5-S1 articulation is normal. There's no findings for degenerative change at all. Same on the on the sacral base tilt projection here. Shows that the L5-S1 articulation is normal. Sacral ala are level. There's no findings for spina bifida. There's no findings for transitional vertebra. And basically the lumbar spine looks pristine, with the exception of these suspicious calcific densities in the right abdominal quadrant, right lower abdominal quadrant. So let's go back to the flexion extension radiographs. So the examiner then conducted his analysis of motion segment integrity, and we'll just draw a couple of lines to depict how those measurements are obtained. So using the measuring tools here embedded within the computer software, we would begin by going to the superior end plate of the L1 vertebra and placing one of our lines there, and then going to the superior end plate of the vertebra below and measuring that angle below. And here we get a positive 3-degree angle. It's positive because these lines are diverging in the back, meaning they're opening in the back, which creates a flexion angle of the motion segment here. That's a flexion angle, a positive angle. As we descend down in the lumbar spine, the angles will become increasingly negative as the lumbar spine assumes an extension or lordosis position. So that's how we make the measurements, and then we simply just move the whole series of lines down segment by segment, adjust them accordingly, and measure the angles. Okay, so we won't go through the measurement of every angle here on the flexion and extension studies. We'll simply present the findings as they were described by the qualified medical evaluator. So here are the findings on the analysis of motion segment integrity as they're described by the QME. The QME provides all of his measurements here on the flexion radiographs in this column, all of his findings on the extension radiograph in this column. Then the qualified medical evaluator does the math formula to come up with total angular motion. At L1, L2, he found 5 degrees of angular motion, L2, L3, 8 degrees, L3, L4, 9 degrees, L4, L5, 7 degrees, and L5, 8 degrees. Well, notice the footnote here. This is right out of the AMA guides. It tells us that in the lumbar spine, there's a gradual increase in flexion extension movement from about 12 degrees at L1 to L2. Okay, 12 degrees at L1 to L2. We're coming up with 5 degrees at L1 and L2. So that's indicative of decreased intersegmental motion. And then from L1 to L2, movement gradually increases to approximately 20 degrees down at the bottom of the lumbar spine, so that by the time we get down here to L5-S1, we're expecting to see approximately 20 degrees of angular motion. So if L1, L2 is supposed to be 12 degrees, L2, L3 we might expect to be 14 degrees, L3, L4 we might expect to be 16 degrees, L4, L5 we might expect to be 18 degrees, and then finally L5-S1 approximately 20 degrees. So based upon this description from the AMA guides, Mr. Jones demonstrates decreased spinal intersegmental motion at each level of the spine, So Mr. Jones has globally decreased intersegmental motion at each level of the spine, and the qualified medical evaluator that this is not indicative of loss of motion segment integrity of one individual vertebrae, but rather because the finding is universal throughout the entirety of the lumbar spine, that this is a radiographic finding for muscle guarding. This is the conclusion of this particular qualified medical evaluator, is that because each spinal segment demonstrates diminished range of motion, that this is not so much a finding of pathologic loss of motion segment integrity, but rather is a global decrease in range of motion, either due to poor cooperation on the part of the examinee, or perhaps due to global muscle guarding of the lumbar spine paraspinal muscles. And we'll see how this factors in to the qualified medical evaluator's opinions and conclusions here shortly. So now the qualified medical evaluator has fulfilled his obligation. He's reviewed the lumbar spine x-ray studies. He's provided a report of findings of the studies. He's conducted an analysis of motion segment integrity. And now, throughout the remainder of the report, the qualified medical evaluator begins to track down the significance of the coarse calcifications that were described by both the medical radiologist and that he himself observed in the x-ray studies. So now, within the body of the report, the qualified medical evaluator begins to explain what's going to happen and what is the significance of this findings of kidney stones. So he states within the body of his report, he states, on 4/10/18, I made a telephone call to a medical radiologist who provided the initial report of findings. That was Town MD. Town MD was not available, and I thus spoke with the attending radiologist, who was Papa MD. Papa MD and I reviewed the x-ray images together. Papa MD confirmed 2 kidney stones in what she referred to as the inferior pole of the kidney. So the medical radiologist now is providing new and additional information, specifically localizing these 2 coarse calcifications in the inferior pole of the kidney. Well, in order to further define these stones, and if medically necessary, Papa MD suggested additional CT abdomen studies. Thus, on a non-industrial basis, I forward this recommendation on to Mr. Jones. So here the qualified medical evaluator fulfills his obligation in forwarding this recommendation from the medical radiologist. And the qualified medical evaluator elaborates and tells us that in order to investigate the new x-ray finding of coarse calcification in the right mid-abdomen, which could be secondary to renal stones, and the significance of this finding in relation to Mr. Jones' report of lower back pain, medical research was necessary. Medical research, which he attaches to this report, was conducted as follows. And here the qualified medical evaluator provides the references that he relies upon, and there's going to be 2 references. Here is the first reference, but the qualified medical evaluator gives us both of his references and the citations from those references upon which his opinions and conclusions later in the report are going to rely. So the first reference was encountered through a web search on a Radiopedia, which is a radiology website, where he found an article related to urolithiasis. Okay, and he tells us that urolithiasis refers to the presence of calculi anywhere along the course of the urinary tracts. So he's telling us that Mr. Jones has a urolithiasis somewhere along the inferior pole of the kidney. For the purpose of this article, the terms urolithiasis, nephrolithiasis, and renal or kidney stones are used interchangeably, although some authors have slightly varying definitions of each. This medical research tells us that although some renal stones remain asymptomatic, most will result in pain. Small stones that arise in the kidney are more likely to pass into the ureter, where they may result in renal colic. Hematuria, or blood in the urine, although common, may be absent in about 15% of patients. Strangury is also occasionally present. Some patients may also present with a complication of obstructive pyelonephritis and may therefore have a septic clinical presentation. And he continues with his reference. He tells us that according to Radiopedia, indications for surgical management include larger stones. Typically, those above 5 millimeters in size need to be surgically removed, and the qualified medical evaluator here does something brilliant, which is what I suggest that you do as well, and that is he relates the medical research to his particular examinee, and he tells us that in the case of Mr. Jones, he has 2 stones greater than 5 millimeters. So this would suggest that Mr. Jones is going to require a surgical removal of these larger stones because according to Radiopedia, indications for surgical management include those types of stones present in the case of Mr. Jones. Those with extended durations of symptoms, the location of the stone with more proximal calculi less likely to spontaneously pass, and this is the case of Mr. Jones with stones within the body of the kidney itself. So those stones that are more distal in the urinary tract, such as in the ureter or even in the bladder, are more likely to spontaneously pass, whereas proximal calculi remain stuck and unable to pass. So the qualified medical evaluator here is relating the medical research, particularly to the case at hand, which is Mr. Jones's case. Infection or septic features require surgical management. Certain professions, such as airline pilot or truck driver, due to the risk of renal colic during work, or those who have failed conservative management. So the qualified medical evaluator raises several issues that specifically relate to his particular examinee. Now, the next reference, the qualified medical evaluator cites the reference, which is a study in the Journal of Clinical Nephrology entitled Ureteroscopic Treatment of Patients with Small, Painful, but Non-Obstructing Renal Stones. This is referred to as the small stone syndrome. And let's just read some of the citations that the qualified medical evaluator determined to be important in this particular case. He tells us that although it's thought that renal colic results from urinary tract obstruction, some patients who are evaluated for renal calculi are found to have no source for their pain other than small non-obstructing renal calyceal stones. Calyceal stones within the renal calyces. We refer to this as the small stone syndrome. We aim to determine if small non-obstructing calyceal stones may also cause pain and that treatment may relieve this pain. A retrospective chart review was performed to identify patients with non-obstructing calyceal stones who were evaluated for flank pain and treated by ureteroscopy. Patients completed a follow-up questionnaire regarding pre- and post-operative pain and quality of life. 13 patients were included in the analysis. The mean stone diameter was 3 millimeters. Following ureteroscopy, 11 patients reported complete resolution of pain and 2 reported partial resolution. 12 patients were able to describe preoperative and postoperative quality of life, and of these, 8 had improved quality of life, 4 had no change, and none reported worsening in their quality of life. Follow-up imaging was available in 10 patients. Stone-free findings were found in 6 patients. Reduction in stone size was found in 3 patients. And despite treatment, 1 patient had a stone that was unchanged in size. So the conclusion of this study, which is relevant to the report at hand, is that ureteroscopic treatment of painful, small, non-obstructing renal calyceal stones achieves complete or partial resolution of pain in all patients and improvement in quality of life in a majority of patients. So now that the qualified medical evaluator has provided citations from the medical research, he now, within the body of his report, starts to explain his interpretation of the medical research and his interpretation as to the significance of the medical research on the particular case in front of him. And he tells us that Mr. Jones' X-ray images depict 2 kidney stones. One of them is large, measuring 2.4 centimeters, and another is smaller, measuring 1 centimeter. These stones are located within the interior of the kidney and are too large to pass out in the urine. They are not obstructing the outflow of urine and therefore are referred to in the references above as non-obstructing kidney stones. These are non-industrial conditions. Qualified medical evaluator tells us these are non-industrial conditions. According to the study above in the journal Clinical Nephrology, these are sources of back pain similar to that which is described by Mr. Jones. So the qualified medical evaluator determined through the use of medical research that kidney stones can cause back pain. Well, lo and behold, this particular examinee has radiographic findings for kidney stones. He has radiographic findings for a painful lower back condition in the form of kidney stones. This is interesting because the lumbar spine itself is nearly pristine. The only remotely significant finding on the lumbar spine X-rays is perhaps early thinning of the posterior aspect of the L5-S1 disc. Otherwise, all disc spaces are very well preserved, and there's no findings for degenerative change. There's no anomaly. There's no scoliosis. There's no particular significant X-ray finding to explain the examinee's report of ongoing lower back pain now 6 months after a minimal mechanism of injury. But there are radiographic findings for non-industrial painful conditions in the form of non-obstructing urolithiasis. And the qualified medical evaluator does a fabulous job by including images within the body of his report underneath the section Medical Research. And he tells us that above our 2 X-ray images, the one on the left, this one here, comes from the Radiopedia website under the search term kidney stones. So this one here is depicting a kidney stone. The image depicts a large stone on the right side of the image. The image on the right is of Mr. Jones, which depicts an even larger stone, also on the right side of the image, along with a smaller stone below and to the right of the first. So he points out to the reader of the report, here are the kidney stones, and he refers these kidney stones to a documented image found on the Radiopedia website, also depicting a kidney stone. So the locations are similar, the appearances are similar, the description as described by the medical radiologist describes kidney stones. So the qualified medical evaluator is specifically identifying these findings concretely as kidney stones, and he provides the reader of the report with a visual image picture so that the reader of the report can relate to these findings. And the qualified medical evaluator then gives us his impressions to summarize the diagnostic studies. He tells us that Mr. Jones has a normal lumbar spine. The medical radiologist of Sacramento Diagnostic Imaging described mild degenerative changes at L5-S1, but I do not appreciate this on my viewing except for perhaps early posterior thinning of the L5-S1 disc space. There are no unusual anomalies of the lumbar spine. Analysis of motion segment integrity reveals globally diminished lumbar intersegmental motion. He tells us what this means. He tells us this is a radiographic finding for muscle guarding, and this finding is consistent with the physical examination findings for decreased lumbar spine range of motion and flexion. X-rays are significant for 2 large kidney stones on the right. And he then goes on in the causation section of his report to handle now the disputed issue related to AOE-COE in this particular case. And I want to read for you now the remainder of the conclusions of this qualified medical evaluator's report and how he incorporates the medical research now to resolve the disputed issue of AOE-COE. Recall that this case involved a denied claim, and the qualified medical evaluator was assigned to this claim to handle the dispute over compensability under Labor Code 4060. So this is where the findings and the medical research are going to support the qualified medical evaluator's ultimate opinions and conclusions on disputed issues in this case. So the qualified medical evaluator cites the causation questions that were posed to him by the parties. So the applicant attorney asked, are the medical findings consistent with the original incident of injury? Please tell us if you find any other industrial injuries and whether you find any compensable consequence injuries to any body system. The claims administrator, the one who denied the claim, please ask the qualified medical evaluator, do you feel that the current lower back pain complaints are caused or aggravated by the examinee's employment with the fast food restaurant? And it asked, please tell us your present findings, please tell us your diagnosis and prognosis, and tell us the relationship of those findings to the above mentioned injury. So these are the causation questions posed by the parties. Well, the qualified medical evaluator answers these questions. First, he addresses the injuries and the compensable consequence possible injuries. The qualified medical evaluator tells us, Mr. Jones reports an injury to the lumbar spine as the only body part involved with the current claim for industrial injury. He does not claim any compensable consequence injuries to other body parts. Okay? So no, there's no compensable consequence injuries to other body parts. He then addresses the consistency of the medical findings. He tells us that there are no medical findings. Aside from trace findings for lower back stiffness, Mr. Jones provided a normal lumbar spine examination. There are no findings for radiculopathy or non-verifiable radiculopathy. If indeed Mr. Jones suffered industrial lower back injury on the date of injury, the injury has now resolved. Stated differently, the medical findings are consistent with a resolved lumbar strain injury. So the qualified medical evaluator tells us that he's not certain if Mr. Jones actually suffered an injury or not, but if he did suffer an injury, any injury that he suffered has now resolved. With regards to the current complaints, Mr. Jones currently reports lower back pain symptoms. However, by his description, the pain is mostly minimal. When he experiences pain, the pain responds well to over-the-counter Tylenol medication. According to Mr. Jones, his pain does not really interfere with activity. Mr. Jones does not have limitations with activities of daily living. If indeed an industrial injury occurred on 9/21/18, that injury has resolved due to time, due to medical treatment, and due to total temporary disability. His current symptoms are not due to the industrial injury, if indeed an industrial injury occurred, as a matter of fact. So the qualified medical evaluator does not discount that Mr. Jones does have current lower back pain symptoms, but he concludes that those lower back pain symptoms are not due to the industrial injury. So therefore, they must be due to something else. With regards to the diagnosis and prognosis, Mr. Jones provided a normal lumbar spine exam. I was unable to identify a bona fide active symptomatic condition of the lumbar spine. New x-rays are negative for symptomatic condition of the lumbar spine. If indeed an industrial injury occurred on 9/21/18, that injury has resolved. If indeed an industrial injury occurred on 9/21/18, the diagnosis is lumbar strain resolved. Okay? So the qualified medical evaluator is setting the stage for his ultimate opinion and conclusion. And then he provides us that ultimate opinion and conclusion in the discussion section of his report. He tells us, Mr. Jones describes an injury to the lumbar spine sustained in the course of lifting and emptying a mop bucket. With Mr. Jones' help in identifying the type of mop bucket involved, I estimate the weight of the mop bucket to be 40 to 55 pounds. Typically, emptying of a mop bucket involves tipping the bucket over a drain, in which case the lifting involved is only a fraction of the weight of the apparatus. In contrast to this, Mr. Jones describes a full lifting of the entire bucket, while also in a cramped space in order to drain the bucket. This involves significantly more lifting with greater load to the lower back. This was an unwitnessed injury that occurred while Mr. Jones was working in isolation. Thus, the occurrence or non-occurrence of an industrial injury in this case is a question of fact. The medical records on the date of the injury from the emergency room do indeed document a bona fide condition of the lumbar spine, which was referred to as back muscle spasm. However, this does not evidence an industrial cause of the condition. Remember, the dispute in this case was over the cause, was over causation. Nobody disputes that Mr. Jones indeed had back pain or indeed had a bona fide condition of the lumbar spine. The dispute was over the cause of the condition. Because Mr. Jones cannot prove the occurrence of an industrial injury, the claims administrator has denied the claim for industrial injury. Therefore, the occurrence or non-occurrence of an industrial injury can only be resolved by the trier of fact. Further complicating this confusion are new X-ray findings significant for renal stones. The renal stones depicted in Mr. Jones' X-rays are large. These are too large to be passed in the urine, and they remain stuck in the kidney itself. These stones are known causes of back pain, and he refers us here to the medical research above, wherein the medical research describes kidney stones as sources of lower back pain. These are sources of back pain similar to the back pain that Mr. Jones describes. It is my opinion that these stones are the cause of Mr. Jones' current back pain symptoms. Boom! Boom! Here the qualified medical evaluator brings home the medical research into his opinions and conclusions and supports his opinions and conclusions with the findings of the medical research. He tells us that this makes sense in the context of a normal lumbar spine exam, normal lumbar spine x-rays, no limitations to activities of daily living due to a painful lumbar spine condition. Further, these kidney stones were the likely cause of Mr. Jones' original complaints of back pain when he reported industrial lower back injury. This makes sense also in the context of his physical examination at the emergency department, which described only back muscle spasm as the diagnosis. So the qualified medical evaluator is effectively stating that he considers Mr. Jones' current report of back pain symptoms to be due to kidney stones, but the qualified medical evaluator tells us that to ascribe Mr. Jones' back pain symptoms on the date of injury 6 months ago to renal stones would require some conjecture. In other words, the qualified medical evaluator is admitting here that he cannot specifically relate the back pain on the date of injury to renal stones because that would require guess, conjecture, surmise, and speculation. And he gives some reasons why. Tells us that there were no x-rays taken at the emergency department on this date, and therefore the presence of renal stones on that particular date cannot be confirmed. Further, the medical records from the emergency department describe physical examination findings of diffusely tender on the right lateral lumbar area, mid-posterior clavicular line with associated muscular hypertonicity. These findings would be consistent with renal stones. However, there is no x-ray evidence of such renal stones. For these reasons, although I consider that Mr. Jones presented to the emergency room on 9/21/18 with symptoms due to renal stones, I cannot so state within reasonable medical probability, because to do so would require speculation. Therefore, with all that said, it's my opinion that Mr. Jones did sustain industrial injury as he alleges. Because there are no facts either to contest or to support his allegation, I base this opinion on his credible testimony. In total, I found Mr. Jones to be credible. In contrast to many examinees, Mr. Jones did not attempt to magnify or exaggerate his condition. He did not overstate his symptoms out of proportion to his actual presentation in front of me. He did not fabricate untrue limitations to activities of daily living. He did not sandbag the physical examination. I found these factors credible, and this bolstered my confidence in Mr. Jones. The remainder of the conclusions of this report are based upon what I consider to be a bona fide industrial injury as alleged by Mr. Jones. So then in the remainder of the report, the qualified medical evaluator goes on to provide his opinions and conclusions on the basis of a bona fide industrial injury on the date of injury as it was described by the examinee, but he declares that particular injury to be permanent and stationary several months prior to the qualified medical evaluation, and he ascribes the current complaints of lower back pain due to not the industrial injury, but rather due to the non-industrial condition of renal stones. And he provides a permanent impairment rating due to the radiographic finding of global muscle guarding as evidenced by globally reduced spinal intersegmental motion at each level of the lumbar spine. Qualified medical evaluator provides for 5% whole person impairment due to the DRE lumbar category 2 method for rating impairment. But then apportions 100% of the impairment to the renal stones and 0% due to the industrial injury. So doctors, isn't this a fascinating case? In my opinion and in my review of this case, the injured worker receives a win because the qualified medical evaluator acknowledges the existence of an original industrial injury and approves and authenticates AOE-COE, which allows the examinee to receive some benefits for the medical treatment that he received and also for the total temporary disability period of 4 to 6 months. But the claims administrator also gets a win because the qualified medical evaluator acknowledges that any current symptoms and any current impairment that the examinee is suffering is likely due to non-industrial conditions. And the qualified medical evaluator supports these opinions and conclusions with bona fide objective findings on the diagnostic studies and medical research, which supports his opinions and conclusions. So the opinions and conclusions of the qualified medical evaluator in this case are basically irrefutable because the qualified medical evaluator relies on objective X-ray findings that are supported by the report of findings by the medical radiologist, and then he conducts medical research which reveals that these findings, these bona fide objective findings, are known causes of back pain similar to the pain reported by this particular examinee, and in the context of a normal lumbar spine exam and in the context of basically a pristine lumbar spine X-ray series, qualified medical evaluator, in my opinion, probably arrived as close as possible to the truth as can be attained in the absence of having a crystal ball. So doctors, this perfectly illustrates the whole point of this program, and that is, as qualified medical evaluators, the parties are relying on us for truthful and accurate opinions and conclusions. They're looking to us to solve the riddle of these cases. And many times the solution to the riddle of these cases can only be accomplished through additional information in addition to the medical records, in addition to the examinee's testimony. And the diagnostic studies are perfect for this. And in those cases, when the diagnostic studies present with unusual or unforeseen findings, medical research many times can help resolve the disputed issues. So doctors, I hope this helps you, and I hope you learned a lot from this program. The take-home message is that in the future, the Division of Workers' Compensation is going to insist that we markedly improve the content and quality of our qualified medical evaluators' reports because of the high stakes and the many parties that are relying upon the opinions and conclusions contained within our reports. So no longer are cavalier and poorly reasoned reports going to be accepted by the parties. In fact, the Division of Workers' Compensation has promulgated new changes to the complexity factors that require medical research in order to qualify for the ML 104 complexity level of billing. So in the future, medical research will likely be required to support your opinions and conclusions. And I say, why not adopt the spirit of the Division of Workers' Compensation's new proposed changes now? Why not adopt that spirit now and begin to improve the content and quality of our reports now? Why don't we just go ahead and get it started now? We have every good reason to go ahead and get started with improving our reports now. So doctors, I hope this helps you, and I hope you enjoyed this program. I want to thank you for taking the time to join me on today's video, and I look forward to being with you on future programs as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.